We have three guests with us today. We have Dr. Craig Katz, who is a clinical professor of psychiatry, of medical education, and with us here in the Department of Global Health at the Icahn School of Medicine at Mount Sinai. He is here in New York City. He has had a number of critical clinical and administrative roles at the medical school, but he had founded and directs Mount Sinai's program in global mental health, which is a particular specialty area of his that grew out of his experience organizing and providing psychiatric services to disaster-affected communities, work that he began in the 90s through an organization that he co-founded and led called Disaster Psychiatry Outreach. He has been involved in the psychiatric response to 9/11 here in New York City. For years, he directed the World Trade Center mental health screening and treatment program for 9/11 responders. And he serves as the faculty director for advocacy for Mount Sinai's Human Rights Program. He's written a number of books and papers related to disaster psychiatry and global psychiatry, including a guide to global mental health practice. And there's much that I think we are looking forward to drawing from him today. We also have joining us Dr. Lukoye Atwoli. Dr. Atwoli is also a psychiatrist, a professor of psychiatry in the Department of Mental Health at Moi University School of Medicine in Eldoret, Kenya. We appreciate him especially joining us from Kenya today by this call. Dr. Atwoli is the former dean of the Moi University School of Medicine, where he was the dean from 2013 to 2019. He specializes in trauma and post-traumatic stress disorders. He has a master's of medicine from the University of Nairobi in Kenya and a PhD in psychiatry from the University of Cape Town in South Africa. He's also currently the global technical director for an organization called Cities Rise, which is a youth mental health program that's being piloted and does work in 5 cities across the world: in Bogota, Colombia, Chennai, India, Nairobi, Kenya, and Sacramento and Seattle in the US. He also serves as the honorary vice president for the Kenyan Medical Association and the honorary secretary general for the African Association of Psychiatrists. So we again really appreciate him joining us globally today. And I'm excited to see that your video is working. We also have Dr. Victoria Nyo, who is an associate professor of community health and social sciences at the City University of New York in the Graduate School of Public Health and Health Policy. She is the director for their City Center for Innovation in Mental Health and an adjunct behavioral scientist at the RAND Corporation. And as a clinical psychologist, her expertise is in developing, evaluating, and implementing evidence-based treatments for depression, anxiety, and trauma in diverse communities in both the US and globally. She's done work to develop research and clinical training capacity and also interventions to support mental health broadly in Vietnam since 2000, including developing the first graduate program in clinical psychology and a program that integrates mental health support services into primary care in Vietnam as well. We're excited to have today, of course, this group with expertise from around the world in different settings, as well as from here in New York, where we're, of course, very much experiencing the global mental health impact of this as well. And I wanted to start by asking our group to share about how people in the communities in which they work, whether locally or diversely, have been coping and what the immediate impacts of COVID-19 and social distancing have been for the particular communities. I'd actually love if you're able, Dr. Nyo, if you'd be willing to perhaps start with the slide you have to reflect for us a bit from the local community here in New York, and then feel free to talk from that about what we're starting to see, and we'll bring in the other panelists from that as well.
Sure. Thank you so much for inviting me. I was wondering if we can share the slides. Was that possible, or should I share my screen?
If you could share your screen, that might be our easiest option for that with how they're coming up. Hooray!
Work?
Yes, it's working. Great. Thank you.
Okay, great. So CUNY School of Public Health has been conducting a weekly survey to look at the impact of COVID-19 on New Yorkers, both New York City as well as New York State. I'm going to be sharing information about New York City specifically. And we're doing this survey for 10 weeks. We are now in week 4. We just released week 4's data. And week 3 is when we started asking about mental health. And so we have 2 weeks of data to share regarding mental health that I'll talk a little bit about. And what we're finding, as you all might expect, is that the mental health rates are really high. People are in a lot of distress. It's been consistently high for the last 2 weeks, and it's been the same percentage point. 40% are reporting that they are socially isolated. And the way we got to that is we asked a question about how socially connected they are on a 4-point scale, and those who said they were not connected at all are the ones that we're considering socially isolated. So no social connections, 40%. 44% are feeling anxious, and that is half of the time. 35% feel depressed at least half of the time. And this week we asked about hopefulness, and 60% of New Yorkers did not feel hopeful about the future. And there was some race differences in that as well, with the highest lack of hopefulness among Asians, 68% compared to whites at 64, and Latinos at 59, and Blacks at 51%. We also asked about economic burden, and in the last 2 weeks, we're seeing that about 29 to 36% are saying that someone in their household has lost a job. And then we've asked about housing concerns, and about 44% are having trouble paying rent or their mortgage in this coming month. And 59% are concerned about being evicted. That's really high, very, very high numbers, very scary numbers. In terms of unemployment and mental health, when we look at those who reported having a job loss in their household, 55% are also saying that they have a high risk of getting sick. 82% feel anxious some of the time, and 73% feel down or hopeless some of the time. And then 11% feel hopeful about the future. As you expect from, and consistent with data from around the world, women tend to be more depressed than men, even though there are no differences in hopelessness, social isolation, and anxiety. Age has been really interesting. We are seeing that respondents who are over 60 are reporting that they're more likely to be socially isolated when compared to the millennials. So it's 45% versus 31%. But the youngest group are the ones that are more likely to manifest anxiety, depression, and hopelessness compared with seniors. And so that might suggest that perhaps seniors are maybe more familiar with being socially isolated, and so they're more used to that. And they probably also have been through other tragedies and other things in life that might have prepared them for this. And perhaps there's some resiliency that's been developed there. Whereas for the millennials, this is probably the first time to experience something at this magnitude, and they're also much more reliant on social connectedness. They're used to it more, and so social isolation may be something that is much more distressing for younger communities. We also saw that those who are 45 to 55 also had high rates as well, which is interesting because I think, I wondered if that was because that group is the group that, if they're going to lose their job, are probably going to have a harder time regaining employment versus, the younger groups who may bounce back. And so there's like different factors that are affecting different age groups. We saw also a difference in race. Latinos report the highest rates of social isolation, 56% compared to other ethnic groups who range between 36 to 39%, and whites who reported 28% to be socially isolated. However, there are no race differences in depression and anxiety. And this pattern was consistent across the last 2 weeks. We also saw that Latinos are, amongst the highest groups of getting, of reporting that they suffered a job loss in their household in the past 2 weeks. So, I think that's consistent with that information. The top stressors for folks when we asked them about what they found to be stressful was their family and loved ones getting sick, about 40%. And then following that is usually themselves getting sick, and then remaining socially isolated was the third. The Asians, interestingly enough, have a different pattern where their second leading stressor was losing a job rather than getting sick themselves. And what's interesting here is the job loss, the actual job loss is higher amongst Hispanics than it is amongst Asian, but Asians have a fear of job loss that is higher, and that's causing them more distress and anxiety. And so, generally, I think, we're seeing what I think is in the media and what everyone has been talking about, which is, the economic impact of COVID-19 and the mental health distress it's causing. I actually think that we in New York are probably faring worse than my partners in Vietnam and in Uganda, where the rates have been very low relative to our rates, and where they have been in Vietnam, they've been sheltering at home since January, really, and so we actually have stopped our project in Vietnam, primarily because the government, and because it's a centralized government, has been very effective. As soon as they put out an order, it's done, around the country within the day. Last week, there was a small outbreak in a small city, Bac Mai, and the whole country was on shutdown. The entire country was like, until that gets resolved, and there was like a handful of cases, nobody's going out, and except for essential workers, basically. But they seem to be doing fairly well. People are just sheltering in and connected to each other, through the internet, as we are. And in Uganda, where I also work, we've also put a break on our project as well, even though there are really very few cases there also. And I think they're more worried about us at this point. So, and with that, I'll hand that over back to you.
Dr. Atwoli, I'm sorry we don't have your video going yet, but let me turn to you and ask, from your perspective in Kenya, what are you seeing in terms of the impacts of social distancing, of COVID in East Africa right now?
Yeah. So thank you very much for having me, and I'm privileged to be on the panel to discuss this important topic. In Kenya, I think over the past 3 weeks, the numbers of people infected with COVID-19 have been increasing. And today, I think we have now 179 confirmed cases. And there's still contact tracing going on, and a lot of activity in all the counties. This week, because Nairobi has had the largest number of confirmed people with COVID-19, restriction of movement has taken effect from Monday. So there's no going into Nairobi or leaving Nairobi for 21 days. And also for some cities along the coast where the numbers of cases have also been high. Mm-hmm. And so across the country, there's been quite a bit of anxiety in many sections of the population, because a lot of the people depend on work that involves getting out and going and doing something with their hands. And so the inability to do this, if this becomes restricted over time, many people fear that they will not be able to take care of their needs. They will not have an income. People who are able have been trying to work from home. So people have been using electronic means. Zoom has become a very popular platform across the country. And many people are staying connected using online and digital means. A lot of the people, the culture in Kenya and in most of East Africa involves a lot of face-to-face. People do a lot of things in physical meetings and getting together over the weekend and eating together and so on. So as this gets restricted, it's interfering with the kind of life that people have been used to in this part of the world. And so there will be consequences. Some of it is starting to show with anxiety, and with difficulty accessing usual services for many of the people. A lot of the hospitals are now focusing on preparedness for dealing with COVID-19, and to some extent, the usual care mechanisms are being interfered with, and yet our numbers are still not as high as what you might have in New York or in other places, but the anticipation is that this is going to increase, and so everybody is preparing to deal with this. So this really is a snapshot of where we are in the country. We have been asked by the government to prepare for, a lot worse before it gets better. And every day there's a briefing that sort of mentally prepares the population for things getting worse before they can get better. So this is what's happening here and in a lot of African countries. I think you will also note that the wave of the pandemic reached our shores a bit later than other parts of the world, Europe and the US. And so we are a bit behind the curve as far as the numbers are concerned. And there's plenty of uncertainty about where this is going to end. There are people who are probably, if you look at it, some people might be irrationally optimistic, saying, well, it's going to end where it is, while others are on the other end where they're extremely pessimistic, saying this is going to be a scourge that's going to affect everyone and it's going to mess up everything. But probably the truth is somewhere in the middle, as long as action is being taken to try and control the spread. So there are people who are guardedly optimistic, who are looking at this as something that we will eventually be able to bring under control.
Sure, thank you for that.
Yeah.
Dr. Katz, turning to you. So certainly the data that Dr. Nyo was presenting from New York are perhaps not surprising, but incredibly sobering right now. And it's helpful to have that in almost real time to go along with the incredible clinical burden and what we're seeing around us right now. What can you share about the immediate impacts from the pandemic for global health right now? For mental health globally here and elsewhere that you are seeing?
Thank you, Dr. Freeman, and for having me, and to my co-panelists for your perspectives. I think, when you look at the current impact of the pandemic here in New York City, at least when I look at it, mostly you're seeing, right, the concerns about health and people getting infected and the economic impact. And I think in terms of the mental health impact, that's going to emerge from those two. And, I think in terms of the types of reactions that we're seeing in people, to some extent, they are so far not necessarily excessive or abnormal, right? It's an anxiety-inducing situation. It's a depressing situation. And I'm struck by, particularly in our patients in East Harlem. I help oversee a clinic for the underserved in East Harlem, or the mental health component of that clinic. And I'm amazed. We have about 50 plus patients that our students actually treat psychiatrically pre-COVID. And I'm struck by how many of them have been economically impacted and how and how many of them also have COVID-19 symptoms. And these are folks that are kind of living, I would say, somewhat at the margins already of our society, just getting by. And almost, I'm not saying all of them, but the overwhelming majority have been impacted, at least economically, and certainly in terms of infection. So it's quite pervasive. In that little cohort of ours, there have been some mental health concerns, but nothing that I think would be out of the normal yet. I think time will tell whether these problems actually mushroom into something that we're going to have to worry about psychiatrically. And in fact, we want people to be anxious right now. If people were not anxious, they wouldn't be doing things as unpleasant as socially isolating. And it's interesting about the social isolation amongst my own patients that I treat individually. Some of them were quite socially isolated before, and they actually feel quite prepared for this. And actually, strangely, and they somewhat guiltily, they actually even feel a little bit better. They ironically feel as though other people, they are not, everyone is in the same boat right now. And they feel badly about feeling that way, but On the other hand, I have a few patients who've just been absolutely devastated by the COVID-19 and even to the point of needing psychiatric hospitalization. So there's been quite a range of reactions.
Sure, sure. That's really helpful. I guess, you know, thinking about that context in terms of, I think both what I'm hearing from all of you in terms of course, the appropriate mental health responses to current situations, and also how people are disproportionate or are impacted in different ways. Are there particular groups that you think are likely to feel the burden of the current situation with mental health challenges, with lack of access to care in disproportionate ways? And whether that's people who are living with particular mental health challenges or conditions already, as well as thinking about, you know, particular groups, whether it's minority groups of either racial, religious, etc., various options, the economically disadvantaged. You know, I think you started from the data from New York, started to see some differences among age and ethnicity and so on. Be curious to hear each of your thoughts about ways in which we might be seeing some differences along those lines. Maybe we'll go back to Dr. Ngo to start, and then kind of ask through each of you as well. We're also going to be continuing to try for where we haven't been able to turn video on again. So if your video comes on unexpectedly, we apologize for that, but would like to see you also. Thank you.
Yeah.
Hi, thank you so much. Yeah, I think, you know, what we are seeing is a very big difference in age effect. And so I think perhaps, you know, if we do some more preventative work with the younger communities, that might be very helpful. And then, you know, certainly for those who are suffering from the economic burden or have someone at home that is sick, could be something that, you know, the two factors that we've been talking about that seems to be the biggest stressors for folks. And so, you know, targeting that community and being prepared for outreaching to that community, you know, after or during the time that we get this, you know, during the time that we respond to COVID is, I think, important.
Mm-hmm. Absolutely.
Yeah.
Dr. Atwoli?
Yeah. So, interestingly in Kenya, the source of the infection, the initial cases were from people who had flown out of the country and came back, and then that is how it started. And so a lot of the perception in the population seemed to be like it might be a problem that could be restricted to Nairobi and probably among people who can afford to fly, actually. And so a lot of the population didn't take the messaging as seriously as one would have liked them to. So the big fear now is from even within Nairobi, if it spreads into the low-income settlements, where access to sanitation might not be as good as in other parts of the city, where the issue of social distancing or physical distancing is a bit confusing because people live in small dwellings, but there are very many people living together, and it is not possible, in my view, to enforce any kind of distancing in that setting in the low-income settlements in Nairobi. So that is a potential place of worry where other mechanisms of control might probably need to be put in place, including providing water, providing sanitary facilities, and providing any other protective equipment that can be found to help these people. Another issue is if you look at people who live in rural areas compared to those who live in urban areas, a lot of the messaging is applicable and working for people who live in urban areas. But people in the rural parts of the country either might not consider themselves to be at as much risk as those living in urban areas. But secondly, they might also not easily take this concept of physical distancing,
Mm.
given the way people live in a communal setting. People do a lot of things together. People often eat together when they live in the same kind of extended household. And so it is very difficult to enforce some of this advice that is being given. And so there are those segments of the population. Initially, when it started again, it looked as if many people were arguing that it is more severe among older folk. And as you know, our population is very young. It's one of the youngest populations in the world, in any case. And so many people thought, again, that would be a protective factor. But then looking at the cases that we have in the country now, the age spread, majority of the people affected and infected are under the age of 60. And so we have to target messaging that, everybody is at risk. And some of the people getting the most severe disease are very young. So we have to think about that as well.
Sure. Thank you.
Yeah.
Dr. Katz, what do you see about disproportionate or variable effects, kind of talking on that a little bit more?
Yeah, I mean, the way I think about this is there are really pretty well-known, I think, evidence-based risk factors for who's going to do poorly from a mental health perspective after trauma and disaster.
Mm-hmm.
And those include so-called dose of exposure, having a prior psychiatric history, prior trauma, although I'd say it's probably how well managed the psychiatric history was and how well managed the prior trauma was. And also having had problems in life before the event, psychosocial problems before, which is kind of intuitive. If things were bad before, you're going to be much more on the edge. And so those are, and then the presence of post-event or during event social support is kind of a mitigating factor, or a lack of social support is a risk factor. So we know those pretty well. So that makes me especially concerned when you think about so-called dose of exposure. Something that we're really worried about here in New York, which is our so-called frontline healthcare workers, the folks that are in the emergency departments and the ICUs and on the COVID-19, what are now becoming COVID-19 units, and all the potential rationing and tough decisions they have to make, and the death they're confronting on a level that I don't think any of us have ever seen before. So that so-called, that group, I think, is, my colleagues, our colleagues, I think are super high risk, which is why actually just this week we rolled out, or late last week, some mental health services for them. And then actually related to what I was talking about earlier, those who were having problems economically and with regard to, let's say, interpersonal violence before the event, whose lives were, again, either in disarray or they were just kind of hanging on, the group that we see in East Harlem. I'm very worried about them over the long term. Those would be the two groups. And of course, the third would be, the aggrieved, people who have lost family members, with the hope that they're able to go through a so-called normal, healthy grieving process, and not one that leaves them not just with the loss of a loved one, but with, accruing a mental health problem in the course of that.
As we, Dr. Katz, I think as we think, from those groups, and certainly, I too, as a physician in this setting and with what's happening right here, am also very concerned for our fellow healthcare providers in the midst of this. Thinking as we think about how might we prioritize and support both our own mental health, our colleagues' mental health, as well as thinking about these vulnerable groups. I would be interested to hear from all of the panelists about suggestions for either coping mechanisms, as well as things that more structurally that institutions can do, that governments can do, things that can be put in place to help mitigate the impact for mental health. And we can keep talking a bit more in our time about longer term implications. I know though, I believe if you could try to share your screen with a slide that you had with some ideas, thinking about, or not ideas, but some evidence really for what has impacted, what might help in the time after trauma. I mean, we could start with you with talking through sort of what might help on various levels to to minimize impact, to move through it in healthy ways, and otherwise deal with some of what is happening right now.
We're talking to me, Dr. Freeman?
Yes, if
Yes,
you
yes.
if you're able to share, we're going to hope.
I had sent the slide, but let me see if I can call up the slide as well that I have and share it.
And I can ask my co-host to whoever can pull it up fast.
Yes. Well, I have one slide that I can show. Wasn't the exact slide I sent, but let me see if I can share my screen.
Okay, terrific. Thank you.
Let's see. Sorry.
Should be no problem. I'm sorry for the
no
quick work. There should be the
share my screen.
Share screen
Okay,
button.
You're seeing my screen, maybe?
No, not yet, unfortunately. Oh, there it is.
Yeah.
Okay.
Perfect.
Yeah. So there's a concept called psychological first aid, and it's really designed to address the very basic approaches that anybody can do. Really, one doesn't need to be a mental health professional. Kind of principles that one can keep in mind in order to address the psychological distress that is arising now, even if it's not a psychiatric disorder. And it really derives from concepts like people may be familiar with Maslow's hierarchy of needs, the idea, that people have basic needs in terms of food and shelter and safety, and then as you go up this so-called pyramid of those needs, you get to like belonging needs and social needs, and then needs that were related to self-actualizing, accomplishing the things that one wants to accomplish and make the difference that one wants to make. Psychological first aid tends to focus on some more of the basics, lower down in the pyramid. And so, we basically want people's basic needs to be met. People need, and this gets to the economically impacted, and I think to what, for example, Dr. Atwoli was talking about, making sure that people have food, water, etc. Trying to keep people together, which is one of these bullets, which is kind of hard in the time of social distancing. But even we are very lucky, for those of us who have internet access, to be able to connect that way, which I can't imagine what this pandemic would be like without having that available to us. We couldn't even be doing this right now. And a big one is information, the third bullet from the bottom, having good, reliable, clear, and what is, we hope, factual information about the state of things on any given day. And we know from the history of pandemics that lack of information, hiding information, or not talking, like there's information from like the Spanish flu back in 1918 that the U.S. government literally made a policy decision to not talk about it, and that seemed to really create a lot more chaos. And so information is really important. And then, my next slides, there is the idea of psychological first aid for children and adolescents, and you may well be familiar with this, Dr. Freeman. And it's listen, protect, connect, LPC. And this is what we can do for our kids. Basically, maybe pay a little more extra attention to them and how they're acting and what they have to say. Kids don't always raise their hand and say, I'm depressed. They might show it depending upon their age. So listening means paying close attention, protecting them, which is what we intuitively do, which is, on one hand, giving them an honest exposure to what's going on, and on the other hand, not too much exposure, and also making sure you understand what they think is going on and helping to kind of debunk any myths, etc. And that's very challenging in the era of the internet, where our kids have such access. And then finally, the C in psychological first aid for kids is connect, connecting them with friends, teachers, etc. And having a routine. Very important for kids to have a routine. All of us to have a routine, but certainly for kids. And to the extent that we can do these things in the era of social distancing, which we can to some degree, and kids, are actually super resilient, probably more resilient than adults. That would be, it's certainly possible to connect, even if we are mostly in our own homes right now. So those are some of my thoughts.
Great, thank you so much for that. That's really helpful. Let's see if we can come out of your screen sharing, and we'll move to the other panelists. Oh, it looks like we now have video for Dr. Atwoli, so it's nice to see you as well. So let's go ahead, since we have that, and turn to to you with these thoughts, what thoughts or what might you share about coping mechanism suggestions in this time? And then we'll move to Dr. Nyo after that
Yeah.
as well.
Yeah, thank you very much. I think Dr. Katz has covered what needs to be done from a systemic perspective to support people going through a difficult time like this. And I would look at contextual, practical steps that individuals can take to take care of their mental health as well. So in the context of firstly, restricted movement and being in one place for long periods of time, I think it is important to have a state of mind in which you have the routine that Dr. Katz talked about, that when you wake up in the morning, you have certain things that you have planned to do in the course of the day and that you do them, and probably review in the evening that you have actually accomplished certain things. So having a certain routine and having certain activities that you have planned to do is an important part of coping. Another important aspect of coping is thinking about life after this particular event. So we have COVID-19, having a mindset that this is going, at some level, is going to be controlled, and we are going to have to do certain things after that, and planning your life around that, and thinking about what will you do differently, what will you do better after this COVID-19 or after it is controlled. I think it keeps the mind active, and it keeps the mind away from ruminating on stressful things. And then having a healthy lifestyle, even when you're cooped up in a small space, eating healthy, getting some exercise so that your body keeps being on the move is also healthy things that would help to promote coping during this time. And another thing, especially in this particular pandemic, which is different from previous pandemics of a similar kind, is a fact that there is a lot of information. There's almost an information overload, and a lot of the information is not clear what is accurate and what's not. So keeping your mind away from COVID-19 related news, COVID-19 related information, and rationing your access to this information, I think is also a useful coping skill, so that you have other things that you do in the course of the day, rather than just spending the day following numbers, tracking deaths, and so on. That can be extremely stressful. So having a plan where you know that maybe between 1 hour, or 5 to 6 p.m. or something, you can check and see what's going on with the rest of the world. But the rest of the day, you do things that are important to you, you connect with people who are close to you. I think that would be an important way of coping with the situation like this. Yeah.
Thank you so much. Dr. Nyo, thoughts on this topic?
Yeah, I think Dr. Katz and Dr. Atwoli has already, shared a lot of great tips about managing stress during COVID-19. I just wanted to reiterate a couple of points that I think are really important, in that, what Dr. Atwoli just said about rationing your information, because we're definitely seeing in some of the qualitative data that we have about people saying that has been helping them a lot, just limiting their access to this information, because it's just, we're getting inundated with this news, and I think it can be particularly stressful for those who are already anxious. And I think most of what we were talking about, a lot of it has been really basic practices for coping that can be very helpful. And a lot of these things help distract us, help ground us in other activities that take our mind off of COVID-19. And I think the other piece is finding ways to give yourself hope. And so whether that be, talking to people, who have recovered, or sharing stories that are positive and other, during your day, expressing gratitude, noticing things that you're grateful for, I think can be very helpful. And contributing in other ways. I think sometimes when you're helping other people, you're helping yourself too, because you find a way of being effective. It promotes self-efficacy, and it promotes connectedness, which is something we all need right now. And so I think that's really important. But all of this is to say, I think that I find it really important is that so many of these skills and behaviors are things that we all can be promoting, which really lends itself to this idea of task shifting mental health care. And I think we're going to need to do that more in this crisis, because we just don't have enough mental health providers to address the needs for the entire world right now. And we were already under capacity, and now it's, off the charts under capacity. And so, I think, and most of the work that I do has been focused on task shifting. So I think what we're going to see is more an acceptance of that, and a need for that, even in high resource settings like the United States. And so, hopefully this, the silver lining here is that we raise more awareness about mental health, and we make more people mental health activists and providers, and we can all be a gateway to that. And so, and I'll end with that.
Sure. Could I ask you, could you talk a little bit more about what the idea of task shifting looks like in a community or in a health system in that way, for people who might not be as familiar with that, and especially thinking about how that, and also maybe with the caveat of how also can we task shift in this particular time when we can't have as much face-to-face contact either between people.
Yeah. So much of the literature on task shifting in mental health is really focused around this idea of simplifying complex interventions, breaking them into small parts, and identifying what the core components are, and teaching people who do not have the mental health specialty background to do specific tasks like screening, like providing psychoeducation, like teaching very basic skills like behavior activation, which we've been talking a little bit about, which is promoting healthy, pleasurable activities. Teaching problem solving is another that has been used in task shifting, which are things that we all do all the time anyways. We may not think about it as that, but every person has to figure out what problems they have and how to manage that problem, and we do it at differing levels. And I think we can find ways to structure that and teach the specifics, concrete skills to break that part down, so that other people can teach someone who's in distress, who might have a harder time thinking about how to problem solve. Mm-hmm. So those are some of the things that have been done around the world, and that's, we have found pretty strong evidence that it works. And, in some of the work that I've done in Vietnam, has been actually just as effective as medication. So, I think it really shows that this can be something that is implemented more broadly. Of course, it's very important that we provide training and supervision to support providers who may not have the mental health background, so that they're also protected, and that there's quality assurance built in, through continuous learning, continuous training. But certainly with the proper supports, it can be done very effectively.
Sure. I think so. We'll shift a little bit towards questions that are coming in from the audience and attendees. And here, please feel free to continue to add to the Q&A box as we go through. I guess a related question is, some are asking, do we predict, or do you think that along these lines, mental health work might continue to be provided via telehealth or these strategies after the pandemic? It certainly sounds, I think Dr. Ngo has excellent both research and practical work providing evidence that can be a long-standing solution, even in times where you don't have this level of crisis. I guess both Dr. Katz, Dr. Atwoli, do you think there's a suggestion that this might work in our settings here in the US, and also in Kenya and elsewhere in your global context, Dr. Atwoli, where we might be able to shift more mental health services to telehealth or other task shifted options?
Yeah, I think even before the pandemic, there have been areas where using digital technology to help people access care has been done. In Eldoret, already every week they were having meetings, tumor boards, to discuss cancer based at the Moi Teaching and Referral Hospital, but then connected to a network of hospitals across the Western Kenya region. And even with the work they're doing with Cities Rise, a lot of it is about connecting young people across a huge, diverse geography using digital technology. And so that the proof of concept has already been done. The key thing at this time is to see what particular services in mental health can be delivered using that model. There is obviously a role for telepsychiatry right now for continuing care, in the sense that if somebody has already been seen, has a diagnosis, attends clinic every so often, then there is absolutely no need for them to have to travel a long distance to have an in-person consult, and they could have a digital consult and they would benefit from that. And this is happening in many parts of Kenya because people have access to mobile phones. I think mobile phone penetration is one of the highest in the world. Mm-hmm. And so everybody has access to a system through which they can speak to their doctor or their provider. There are things that we will have to test in the kinds of mental health delivery. Like if somebody new onset psychotic symptoms, for instance, might be a little difficult to use that model to deliver care, and so on. So these are things that we will learn out of this pandemic, and we will be able to get certain things that people can actually do for themselves. We will find other things that people can get help from their relatives or significant others, and then we will distill things that must be delivered by a professional, and then decide what requires face-to-face and what can be delivered using technology.
Sure. Yeah. Dr. Neal, there are a few questions that you can probably clarify pretty easily related to the survey here in New York in terms of, is this being done online? Is it being done through calling? Is it continuing? And I guess also along with the question of like, if it's going online, how are you trying to keep it as a representative sample in that context? Maybe you can help us with a few details related to the survey structure.
Sure. Yes, it's being done actually in 3 different ways. It's being done online and on the phone and through text messaging. And it's a representative sample of 1,000 people in New York City. And I think about 600, 700 that's done for the rest of the state, mostly upstate. 40% of the samples upstate. There's 15% that's from Long Island, specifically Shirley, Seaford, Glen Cove, Garden City. In New York City, it's about 45% of the sample, Queens, Brooklyn, Manhattan, Staten Island, Bronx. And then the upstate group is Albany, Harrison, Carmel, Rhinebeck, Amsterdam, Schuylerville, Utica, Corning, Buffalo, and Rochester. And so we hired a polling company to do this, and they have a panel that they work with, and they created the representative sample based on the American Community Survey model. And so, yeah.
Great, thank you. I think that's really, really helpful. So it's really, to really show how this comprehensive assessment is being done, and it's ongoing. Is that correct?
Yes, it's ongoing. It's going to be for 10 weeks. We vary the questions a little bit from week to week, depending on what's going on. And so this last week, we asked about, people's attitudes about wearing a mask outside, and, how they feel about that. And in the past, it's about, vaccination, if they would get vaccinated, if a vaccine came out. So depending on what's going on.
Terrific. Another question, maybe we'll send this one to Dr. Katz. Any additional suggestions for how we might get out in front of the mental health needs for high-risk groups, both now and in the near future, as we look to what might be done next?
Well, I think that looking at, let's say, the health professionals in particular, I think that just like our employer, let's say here at Mount Sinai, requires us to do an annual health assessment each year. I think once we hopefully pass through the so-called acute period, I think there should be a mandated sort of mental health checkup online that would probably basic screen for major depression, PTSD, maybe recurrent alcohol use. Those are like the big 3 after trauma, disaster, and very proactively and in a mandated way screen for all that. which I think actually was a good idea before all this, but I think is an even better idea now.
Sure.
And connect people with now hopefully the hard part is when you screen at that level, you have to have services to back it up. But hopefully we could figure that part out too. I think just conducting those kinds of screenings would send a good message as well, regardless of the results. I also do think, to get back to the telehealth perspective,
Mhm.
I do think that it's a great way to increase access, and we have lots of experience before this using telehealth. And I think that we shouldn't consider it like a backup or but actually a primary way of delivering mental health care, because there's plenty of evidence to support it. We have plenty of experience doing it. And I think back to after 9/11, when we set up our 9/11 program here at Mount Sinai, one of the biggest issues we had was finding space to see the patients. We could not find space. Anyone who's in New York knows what that's like, or in a congested area. With telehealth, you really don't have to worry about space. We can see a lot of people, assuming we have the human resources to do it. So I really think we should capitalize on what sort of has become like the default. Okay, we'll see you by telehealth because we can't see you in person, and really think of it as a primary platform that's going to increase access and outreach.
Mm-hmm.
Terrific. Thank you so much to all three of you for taking the time to join us today. I know it's, of course, an incredibly busy and intense time with a lot of shifting, very urgent priorities. We really appreciate you spending this hour talking with a wide group of participants about both the data, your perspectives on this, what we're seeing worldwide, and also these really helpful strategies for how we might move forward for here. I know there are a number of additional questions, and when we post the video recording of this, we'll try to also post with it as our panelists are able and willing to maybe prepare a few written notes in response to some of the questions as well. As a quick note, for anyone who is looking for additional resources, whether telehealth options, looking for care or support or additional information, perhaps we'll put links to some resources with the recording, but also for your immediate needs, probably the easiest strategy is to Google Mount Sinai and mental health COVID, and that will bring you to some of the links for the resources that are available locally, particularly as well. And certainly, feel free to reach out related to that if there are needs. Next week, we are excited to be hosting another one of these webinar remote events as well. Our focus next week is going to be on human rights, and particularly prioritizing human rights in the era of COVID-19. Our session next week is going to be taking place on Friday, April 17. It will actually be at the same time as this session at 10 a.m. Eastern Standard Time in the US, and with, again, a number of panelists from both the US and globally. So we really look forward to that opportunity as well, and would welcome people to continue to join us. Thank you so much for your time again. Again, feel free to follow up with the recording and the resources and reaching out for anything that's needed. Thank you.
Thank you.
Thank you very much, Rachel.
Thank you.
Thank you.
For having us.
Thank you.